Okay, let's not waste our time. Let's start. Epidemiology, okay? See, when I talk about this peptic ulcer, as you know, is a very, very common disease, okay? Most of you will be vulnerable for peptic ulcer. So the frequency of peptic ulcer disease in other countries is variable and is determined primarily by the association of major causes of peptic ulcer. That means association of NSAIDs and H. pylori. Many people, especially during these days of corona, they have the fever and they just like that swallow NSAIDs. And remember, that will lead to the GI upsets and pylori. Once that NSAID causes the ulceration or irritation in GI, then H. pylori will join them. So, and this is also very much seasonal, especially this is a very bad season for this, which the NSAIDs people take because of the headache, cold, headache and fever, and then that leads to other kind of stuff. So you should be very aware of that. See, there was a systematic review was done in 2018 and by MedPlus and Medline. They found that the highest annual incidence of peptic ulcer is about 141 people for 100,000. That means 141 per lakh, which is really good number. But whereas in place like UK, it is as low as 23. Okay, almost say like 7-8 times lower than that of the. So peptic ulceration varies from place to place, season to season, and if you talk about now in India, it will be very high. See, now they have found it in Korea. Highest annual incidence is 4.4 per 1,000. Where is 4.4 and where is 141? Okay, so in UK, there is one study showed 2.2. So it is incidence and the incidence, but if you do it in India, it will be very high. If you do it in, especially during this Corona season, it will be very, very high. Okay, so this is seasonal and depends upon all the other factors, connected factors. Okay, so let's see, when you are talking about all those things, not straight away we bulge into the clinical aspects. So as I told you earlier, when a patient comes, first we will look at a clinical presentation. So it will be done basically in two ways. Number one, we need to ask. Number two, we need to touch. Okay, so ask to see, that is why we call it as a clinical history or medical history. History has to be taken, and then we have to get into the examinations. And once you ask, then you touch, and then that will give you a clear understanding what may be the thing, and then you get into the investigations, and in meanwhile you would have had some kind of a thinking as to what may be the disease. That is called as provisional diagnosis. And when you make a provisional diagnosis, it will say maybe this, maybe this, maybe this, maybe this. That is what we call it as a differential diagnosis. And then we do a clear cut varieties of investigative procedures that will give you confirmed diagnosis. Okay, that is a flow that we are doing as far as this is concerned. Once you are very sure this is the disease, and then get into therapeutic aspects. How do you treat? The first and the foremost, what we need to look at is treat without using drugs. As I told you, as far as possible, avoid drugs. If you are giving drugs, give as minimum as possible. Okay, so drugs, that means non-pharmacological treatment, and then it gets into pharmacological treatment. So you as a clinical pharmacist should know both non-pharmacological and pharmacological. And when you pharmacological comes, you need to see there are a lot of drug interactions and adverse drug reactions. So many things are there. So you need to know about all those things, and then you need to come to a stage as to whether this is the progression, disease progression, how it's happening, and with understanding of all the earlier understanding will lead you to a stage where it is a disease cessation will come. Okay, that is a whole strategy of therapeutic. Therapy now, as I'm starting the clinical aspect, therapeutic aspect, our main focus is patient's health. Patient should become clinically totally free from the disease. Okay, so obtaining medical history, especially peptic ulcers, disease, H. pylori infection, and ingestion of the non-steroidal anti-inflammatory drugs, smoking, it is very essential for making the correct diagnosis. Okay, and more than this, and also alcoholism, as we said, alcohol is one of the and any other drugs, any other substances, and life history, the history of or lifestyle also is important. People taking too much of a coffee, people eating irregularly, all those things has to be asked while you take history. That will give you, see, bits and pieces has to come together to give you a clarity. Wow, am I thinking correctly? Then duodenal gastric and duodenal ulcers. So it may say, oh yes, I think this fellow is having ulcers. Then wonder whether it is duodenal ulcers or gastric ulcers. Usually cannot differentiate based on history alone. Then you need to have much more details information to see what is it. So epigastric pain, that is stomach pain, is the most common symptoms of both gastric and duodenal ulcers. One of the common things they say. And this is like burning sensation, a gnawing, that means kind of a dull pain and a burning sensation generally occurs after meals. But if shortly after meal, then it may be a gastric ulcers. If 2 to 3 hours afterwards, then it can be a duodenal ulcer. So all these things, like, when you did a chemistry limit test, chemistry, all those ion identification tests, this, finally CT, you came to confirmation test. Similar logics you have to apply while you're doing this. Okay. Now, food or antacids relieve the pain of the duodenal ulcers, but provide minimum relief of pain in case of the gastric ulcers. So some of these tests will tell you, what kind of a ulcer this person may be having. Now, if the duodenal ulcer pain often awakens the patient at night, So, and he will say, but about 50 to 80% of the patients with duodenal ulcers experience night pain. But whereas only 30 to 40% of the patients with gastric ulcers experience the night pain, and 20 to 40% of pains with no clear dyspepsia. Okay, so these are some of the indications. Now, pain typically follows daily pattern specific to a patient. It is not one all pain, but you see, as long as the disease is there, daily we see that. Pain with radiation, the back is suggestive of posterior penetrating gastric ulcer complicated by pancreatitis. It may not be just the gastritis alone. It cannot be just gastric pain alone. Who is that? Okay. It may not be just gastric pain alone, but it may be some kind of a
Someone unknown.
Unmute, all of you unmute. I've already muted everybody. Somebody is unmuted. Okay. Chalo. So where am I? So patients who develop gastric outlet obstructions also result in chronic untreated duodenal ulcers. Okay. So we need to ask questions to understand what may happen. Usually reports a history of fullness or bloating associated with the nausea and emesis that occurs several hours after the food intake. So bloating means feels stomach being so full, and then vomiting. A common misconception is that adults with the gastric outlet obstruction, patients with nausea and emesis immediately after the meal. So, see, you feel after the meal, you feel so full. That can be one of the indications. Okay, couple of things that are there. Basically, one need to take. And in addition to that, other manifestations include dyspepsia, including belching, bloating. You know what is bloating? Feel so bloated, stomach feels bloated, so enlarged, distension, and fatty food intolerance. You just don't feel like taking or can't take the meat or any other fatty food. Okay. Then also you'll have heartburn. Many people experience some kind of a burning sensation in the heart and chest discomfort. See, one of the many people feel that they have a cardiac problem, so they rush to the hospital thinking that they have developed a cardiac problem. It may be just a chest discomfort. Then the other to that, there may be hematemesis or malignant resulting from gastrointestinal bleeding. That means the stool may have some kind of a blood, and it can be intermittent over several days or multiple episodes even in a single day. So this rarely a briskly bleeding can occur, can present into, see, that rarely, that is not very common, but it can be small traces, and symptoms with consistent anemia may be present, and sudden onset and symptoms of maybe indicate the perforation. So that is going to the next level of peptic ulceration. And generally NSAID induced gastritis or ulcers may be silent, especially in the elderly people, because elderly people, these conditions may not very significantly demonstrate. And only about 20 to 25% of patients with symptoms of suggestive peptic ulcerations are found on ingestion to have the peptic ulceration. So these are not the only this, but these will give some kind of an indication that it is a peptic ulceration. And alarm features that warrant prompt endocrinology can be a bleeding or anemia. That means there are definitely perforations are there, and the person is losing his hemoglobin level. So that means it is not an ordinary one. We have to easily, immediately handle that. And also early satiety. That means just to eat a little bit, he doesn't feel like eating anymore. Early satiety. And unexplained weight loss. And then progressive dysphagia. Then recurrent vomiting. Family history of gastrointestinal cancers. These things, then immediately look at a gastroenterology, take an immediate suggestion, because it may lead to more complications. Okay, so what I told you all this time is asking. That means finding whether there is any kind of a hint towards peptic ulcerations. Always advise never to take a decision conclusion by just asking questions. Next, phase 2 is physical examination. In uncomplicated peptic ulcers, clinical findings are few and non-specific, and it can be epigastric tenderness. That means touch near the stomach portions, and usually mild tenderness, you see, softness, touching when you touch. Then right upper quadrant tenderness may suggest biliary etiology, or less frequently peptic ulcer disease. So you need to see what kind of tenderness is there where. Then the gonic positive stool resulting from occult blood loss. You need to see what kind of a stool, what blood is there, blood is the stool. Then there can be melena resulting from acute or subacute gastrointestinal bleeding. That means there are the traces of the blood from the gastrointestinal bleeding. And then succession splash resulting from partial or complete gastric outlet obstructions. So these things are generally seen by means of clinical findings. And listen, patients with perforated peptic ulcer disease usually present sudden onset of severe, sharp abdominal pain. Okay, severe, sharp abdominal pain. Most patients describe this as a generalized pain, and few patients will say it as a severe epigastric pain. So even slight movements can tremendously worsen their pain. So these patients may become fatal as if not attended to, or so need to be very careful. Abdominal examination usually discloses generalized tenderness. Wherever you touch, there will be tenderness or softness and rebound tenderness, guarding and rigidity. However, degree of the peritoneal findings is strongly influenced by are various factors like size of perforation. That means already the holes have begun over there and we don't know what is the size of perforation. Then amount of the bacterial and that means this pylorus bacterial content, H. pylori, and then the gastric content contamination in the abdominal cavity, then time between the perforation and presentation. That means how quickly you are presented and spontaneous sealing of the perforations. All these factors play an important role to grade the kind of the disease. So patients may also demonstrate signs and symptoms of septic shock. There can be tachycardia. You know what is tachycardia? There can be tachycardia, hypotension, or anuria. So tachycardia and hypotension may make a person feel that they have a cardiac problem. The chest pain may make you feel a patient there is a cardiac problem, but you see, it's all pseudo cardiac issues. So these indicators may be absent in elderly or immunocompromised patients, or even patients with uncontrolled diabetes. And patients should be asking if there is vomiting before the onset of pain. Okay, all these things are very important because it is one need to understand by examination not only the disease but the stage of the disease, also possible complication of the disease. Okay, that is why one need to, with a lot of patients, has to examine. So that is why peptic ulceration, it is differential diagnosis is very important. Peptic ulcer, differential diagnosis. So diagnostic considerations are non-nuclear dyspepsia or functional dyspepsia. Dyspepsia means a condition characterized by upper abdominal symptoms that may include pain or discomfort or bloating or feeling of fullness with very little. Okay, so the functional dyspepsia is a diagnosis of exclusion made in patients with chronic persistent epigastric pain in whom a thorough evaluation shows no organic disease. Okay, so one should not be drawn into conclusion by one or two incidences. That is why we call it as a differential diagnosis. Very important. That's what we call it as a rule out. So patients may primarily have epigastric pain, which is referred to as unlikely dyspepsia, or they may have symptoms of postprandial bloating. That means after food, they feel the stomach is so bloated, with that can be referred to motility like pepsia. And there can be Crohn's disease. Crohn's disease is Crohn ulceration can involve any part of the GI tract, from buccal cavity to up to buccal mucosa to the rectum. It can be anywhere else. So isolated Crohn ulceration of the stomach is rare. So we need to understand, does he have a dyspepsia, non-ulcer dyspepsia? Does he have an ulcer? Does he have a Crohn's disease? And Crohn's disease may also be duodenal or ileal ulceration. It can be any other place. Then the another kind of thing is called as a Zollinger-Ellison syndrome. It's also maybe a rare disorder, but it is connected to GI. So it can cause gastric or duodenal ulcers, and usually multiples from excessive acid secretions. So the Zollinger-Ellison syndrome, if the patient has severe peptic ulceration, that can also have kidney stones, watery diarrhea, malabsorption. It can also be associated with the endocrinal neoplasia type 1, and patients with Zollinger-Ellison syndrome usually have a fasting serum gastric levels of more than 200 picograms per ml, or basal gastric acid hypersecretion of more than 15 milliequivalent per hour. Proton pump inhibitor therapy should be discontinued at 2 weeks before the gastric level be measured. So this is a Zollinger-Ellison syndrome. So one need to understand what exactly is the condition the patient is suffering with. So there are many other diseases are there. I've just listed a few of them. It can be acute cholangitis or acute cholecystitis or biliary colic, or it can be acute coronary syndrome. It can be acute coronary syndrome. It can be acute gastritis, cholecystitis, or chronic gastritis, or it can be emergent treatment of gastroenteritis or esophagitis. So many things, or inflammatory bowel disease, we'll come to that later on, or inflammatory bowel disease, or it can be gastroesophageal reflux disease. Okay, so it can be any of these things. Okay, it can be gastroesophageal reflux disease. Now, we will just look at, once we know this is a differential diagnosis, then we will look at what are the diagnostic features. How can we identify? Okay, it's very important. So we have seen by means of listening, we have seen by means of a physical examination, we are clear, it looks like this. Then the doctor will never give a prescription straight away without giving some diagnosis. Okay, so number one, testing of H. pylori infection is essential in all patients with peptic ulcers. So documentation of peptic ulcer disease depends on radiographic and endoscopic confirmation. Okay, that is, if the diagnosis of peptic ulcer disease is suspected, obtaining a complete CBC is very important. Then liver function test and levels of amylase, lipase may be useful. CBC count and iron studies can help in detecting the anemia, and which is an alarm signal if mandates early endoscopy. And then we may have to see the amount of the blood loss. So this is the diagnosis is very important. So in fact, 2017 ACG guidelines, gastroenterology guidelines, American gastroenterology guidelines recommends post-treatment testing to prove eradication of HP1 with the use of urea breath test. That means the H. pylori infection with urea breath test or fecal antigen test. They also suggest a biopsy-based testing at least 4 weeks following completion of the antimicrobial therapy after the proton pump inhibitor. So you need to confirm whether there's definitely the H. pylori infection, how much is H. pylori infection. Okay, so now when a patient comes with this kind of a treatment emergency to the emergency department, struggling, what they do is first they should do a complete CBC to understand the chronic blood loss, to understand whether there's anemia also, and the blood loss is there. What need to be done if the blood infusion is necessary? The blood loss may be because of the perforations. Then need to understand the electrolytic conditions. Electrolyte, blood urea nitrogen, definitely, and creatinine tells you about the kidney positions. How is kidney doing? Electrolyte also will tell you about the overall, the ionic conditions. These are useful in assessing the critically appearing patients and who require fluids. Then it could immediately start a saline or things like that. Then the screen cross-matched blood transfusions indicated in unstable and potentially critical patients. Then activated partial thromboplastin time, prothrombin time, and international normalized ratio are indicated in patients with active bleeding and those on anticoagulants. Then amylase, lipase, and liver transmanase levels can be helpful to rule out other common causes of epigastric pain. So a patient younger than 55 years with no alarming features should be referred for non-invasive testing of H. pylori infection in the outpatient setting. So we need to, in emergency, quickly understand what may be the conditions. Okay. Now, first of all, we'll come to H. pylori. H. pylori is one of the common and the most prevalent organism for the peptic ulceration. So, the endoscopic or invasive test for H. pylori includes rapid urease test. It's very commonly, very easily, simply done. Rapid urease test, then histopathology and cultures. So rapid urease test is generally the endoscopic diagnostic test of choice. And so the presence of H. pylori in gastric mucosal biopsy specimens is detected by testing the bacterial product of urease. Then fecal antigen testing identifies H. pylori infection by detecting the presence of H. pylori antigens in the stools. Okay, we need to see. Are you familiar with what I'm talking about? H antigens. If at all H. pylori antigens are there in stool, we identify that by giving a necessary antibody, and antigen antibody interaction takes place. Then we say yes, H. pylori antigen is there. The test is more accurate than antibody testing and less expensive than urea breath tests. Okay, so we need to see whether there's really H. pylori is there. There are actually 3 kits. They're called as Clo Test, HB Fast, and Pylori Tech. These are commercially available for H. pylori testing. Each contains a combination of a urea substrate and a pH sensitive indicator. So one or more gastric biopsy specimens are placed in the rapid urease test kit, and to know whether H. pylori is present, and if bacterial urease converts the urea to ammonia and also changes the pH and changes the color. So these are various simple but definite confirmatory testing for H. pylori, which will give us a clear indication as to how one has to go further. Now, urea breath tests detect an active H. pylori infection by testing for enzymatic activity of the bacterial urease. In the presence of urease produced by H. pylori, labeled carbon dioxide, that means the isotopic carbon dioxide that is produced in the stomach, absorbed into the bloodstream, they diffuse into the lungs and inhaled. And then you need to see the radioisotopic carbon that comes out to identify whether there is a urea is there or H. pylori is there. Okay. Also, the histopathology, often considered as the critical, the main standard for the diagnosis of H. pylori infection. If the rapid urease test result is negative, but still there's a high suspicion of H. pylori, then it can be a duodenal ulcer. One need to go a little further. The diagnosis of antibodies to H. pylori can be measured in serum or plasma or whole blood. This results with whole blood test obtained from finger sticks, and then they are also reliable. Okay, so various tests like this are available today. It is very common. And now, once the H. pylori is ruled out or it is confirmed to be present, then need to go for endoscopy. Endoscopy, I'm talking about the visualizing the GI features by means of a camera. Okay, that is endoscopy. So upper gastrointestinal endoscopy is preferred diagnostic test in the evaluation of patients with suspected peptic ulcer disease. Okay, so it is highly sensitive for diagnosis of gastric and duodenal ulcers. It allows the biopsies, cytological brushings also in the settings of a gastric ulcers to differentiate a benign ulcers to malignant lesions, and also allows for the detection of H. pylori infection with anterior biopsies for rapid urease test or histopathology in patients with peptic ulceration. In other terms, this endoscopy is sending a camera or camera mounted probes in there, and which will not only see but also will bring the brushings for the cytological examination. So at endoscopy, the gastric ulcers appear as discrete mucosal lesions with a punch out smooth ulcer base, and often is filled with whitish fibroid exudate. So ulcers tend to be solitary, or it can be individual, well circumscribed, and usually are about 0.5 to 2.5 centimeter in diameter, small to big, Most ulcers tend to occur at the junction of the fundus and antrum. Okay, you know where is fundus in the stomach? Fundus and antrum along the lesser curvature. Benign ulcers, see, lesser curvature means there is a small curvature of the stomach. Benign ulcers tend to have a smooth, regular, rounded edge with flat, smooth base and surrounding mucosa that allows radiating folds. So malignant ulcers usually have irregular shape, heaped up and overhanging margins. Okay, very clear. By looking at the endoscopy, you can very clearly say whether it is a benign or carcinogenic. The ulcerated mass often protrudes into the lumen and folds surrounding of the ulcer, and it can become often nodular or irregular. It's very important to see what kind of an ulcers that person has. This endoscopy will give you pictures. Look at some of the pictures of endoscopy. See, peptic ulcer, first picture I'm showing you is peptic ulcer, gastric ulcers with punched out ulcer base and whitish fibroid exudate. Okay, which is then here you see the gastric cancer with ulcerated mass. That's how you see there overgrowth. Here, this is again a gastric cancer. Now, irregular heaped overhanging margins. So, that again is a complicated condition. Whereas here, gastric ulcer with a punched out ulcer having whitish or whitish exudate. Okay, that is so. Any of this kind of a situation you see well inside the stomach, then can be which can be easily visualized by means of endoscopy. More than 95% of the duodenal ulcers are found in the first part of the duodenum. More than about 1 centimeter of diameter. They are mostly are about less than 1 centimeter diameter, and duodenal ulcers are characterized by the presence of well demarcated breaks in the mucosa that are extended into muscularis propria of the duodenum. See, I have given you two pictures over here. This endoscopic view of the ulcer in the wall of the duodenum on the first part of the small intestine. This ulcer is an open sore. Okay, whereas here you see the peptic ulcer disease, the duodenal ulcer in a 65-year-old man with osteoarthritis who presented with hematostasis and melania. The patient took naprox on a daily basis. See, this is, see, you can see there the bleeding also happening from that point. Okay, so that is about the, just briefly I told you about the endoscopy. Now let's get into next. The patients who presently acutely chest pain may be useful to detect the free abdominal air when perforation is suspected. So chest X-ray is very important, or the X-ray is very important. The upper GI contrast study with the water soluble contrast, the the extravasation of contrast indicates gastric perforation. In other terms, by sending an endoscopy, you see from inside. By doing an X-ray, you see from outside. So you see how is a whole. Double contrast radiography performed by an expert radiologist may approach a diagnostic accuracy of upper GI endoscopy. Okay, so very important. See, in these cases, we should never take a chance. We should never do the treatment by means of a hypothesis. Maybe here like this way, take this. No, 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 no. Definitely this is what has happened. Take this medication. Is a language that clinician has to use. That is why this approach is suggested. However, it has been replaced largely by diagnostic endoscopy. When available, the upper GI series is not as sensitive as endoscopy for established diagnosis of a small ulcer. So if you have to say definite, then the endoscopy is much better than that of this. So various. So if it is biopsies to denote malignancy in setting of the gastric ulcers, then you need radiography also for this. Okay. Then there is something called as angiography. What is angiography? Angiography is that we send an ink or a dye into the blood vessels, which will understand the distribution of the blood vessels. So you see angiography for the cardiac patients, where the blocking in the vessels is identified by means of angiography. So angiography may be necessary in patients with massive gastrointestinal bleed in whom endoscopy cannot be performed. So an ongoing bleeding rate of 0.5 ml per minute or more is needed for the angiography to be able to accurately identify the bleeding source. So when you color the blood, when you put a dye, then angiography will say which blood vessel, how much is torn, detect the bleeding point, and helps for necessary therapy, but directly injecting the vasoconstrictive agents. So therapeutically, and sometimes you can ligate over there to deliver the patient. Okay. Now, another diagnostic method is serum gastrin level. Fasting serum gastrin level should be obtained in certain cases to screen Zollinger-Ellison syndrome. That means patients with multiple ulcers occurring distal to duodenal bulb, strong patient history, family history of peptic ulcers associated with diarrhea, then weight loss, peptic ulcers not associated with H. pylori infection, not using non-steroidal anti-inflammatory drugs, peptic ulcers associated with hypercalcemia and renal stones, ulcer refractive to medical therapy, ulcers recurring after surgery. These kind of conditions, it's important to take the gastric content, serum gastric value to rule out. Then secretin stimulation test. Secretin stimulation test may be required if diagnosis of Zollinger-Ellison syndrome cannot be made on the basis of the gastric serum alone. Very important that you need to get into much more specific confirmatory test to say that this is this. So the test can be distinguished Zollinger-Ellison syndrome from other conditions with a high serum gastrin content, such as the anti-secretory therapy, proton pump inhibitor, renal failures, or gastric outlet obstruction. So serum secretin stimulation test is very important. Then next we'll get into biopsies. That means when the endoscopy goes in, that has got a biopsy brushes, then it will just take a cytological brushes of the tissues. Need be take a small section of it, and then a single biopsy offers 70% accuracy in diagnostic gastric cancers. Seven of the seven, but the seven, but the sensitivity of to 99% accuracy, it's very important. So that is why we need to get into more accurate, sensitive diagnostic procedures to ascertain that this is the condition. Okay, the brush cytology has been shown to increase the biopsy yield. And see, because in brush cytology, you just go there, brush it something like this, it will collect all from the external, bring it and then brush it on the slide. Okay, and this method is useful, particularly when bleeding is concerned to be patient with coagulopathy. Okay, then in terms of histology of gastric ulcer depends upon its chronicity. The surface is covered with a slough and inflammatory debris. Beneath this is neutrophilic infiltration, active granulation with non-nuclear and leukocytic infiltration, and fibroid necrosis may be seen. So in chronic superficial gastritis, lymphocytes, monocytes, plasma cells often infiltrate into the mucosa and submucosa. So the histological finding is, that's why it's very important. Okay, so with all these things now, I discussed with you various diagnostic tests to confirm whether the patient has his peptic ulcers or not. If the peptic If the patient does not have peptic ulceration, then we need to think something else. But that is why you have to have a confirmatory test, you have to have a repeat confirmatory test, rule out all the other conditions, and to say that the patient has peptic ulceration. Now, if you say patient has peptic ulceration, then we get into the treatments and management of peptic ulceration. First, treatment of peptic ulceration varies from the etiology and clinical presentation. See, remember one thing, it is not uniform, it is not same for every patient. It is very important to understand the etiology and clinical presentation to plan the management. So initial management of a stable patient with dyspepsia differs from the management of an unstable patient with upper GI hemorrhages. Okay. So in the case of upper GI hemorrhage case, the failure of medical management not uncommonly leads to surgical intervention. Sometimes if there is a case, we need to move away from just the therapeutic, that means the medication, to the surgical interventions. Okay. So treatment options include empiric secretory therapy. What is empiric secretory therapy? Anti-secretory therapy. That means inside the acid is secreted, H ions are secreted, so you need to block the H ion secretion. How do you block the H ion secretion? You have the PPI, protein pump inhibitors. Protein pump inhibitors, it will inhibit the pumping of the hydrogen. And otherwise, H2 blocker, they block the histamine receptor and inhibit the pumping of the acid. Then there's the other called as empiric triple therapy of pylori infection. That means it is the antibiotic, PPIs are included in the triple therapy. Then endoscopy followed by appropriate therapy based on the findings, and then H. pylori serology, and then followed by triple therapy for patients who are infected. And generally, breath testing for H. pylori is used to identify whether there is a H. pylori. Endoscopy is very important, is required to document the healing of the gastric ulcers and to rule out gastric ulcers. This usually is performed 6 to 8 weeks after the initial diagnosis of the peptic ulcers. So documentation of H. pylori with a non-invasive test such as breath urea and fecal addition test is appropriate for patients with complicated ulcers. Okay, so this, what I'm trying to tell you, is the generalized strategy for treatment. And okay, so it depends upon the condition to condition. For most patients with peptic ulcer disease are treated successfully with cure of H. pylori infection and avoiding any kind of an instigator like NSAIDs. And then there are some computer models that suggested that obtaining H. pylori serology followed by triple therapy for patients who are infected, where is the most cost-effective approach. There are various strategies out there. Endoscopy should be performed early in the patients older than 45 to 50, and in patients who are associated with so-called alarm symptoms such as dyspepsia, weight loss, recurrent vomiting, bleeding, etc. Okay, so then the indications for urgent surgery includes failure to achieve hemostasis endoscopically, then means the bleeding is continuously happening, recurrent bleeding despite endoscopic attempts to achieving the hemostasis, or perforations. Many authorities recommend a simple overview of the ulcers with treatment of underlying H. pylori infection, cessation of NSAID bleeding, NSAID for bleeding peptic ulcer disease, and need be, they get into some kind of a surgical options. Okay, so this is my brief for this one, and the next class we will see what is the other strategies drawn out, and then we'll straight away run into the medications. So you have studied, you are in 4th year now. In 3rd year, I think you have finished the GI pharmacology. Have you finished pharmacology too or not?
Yes, sir.
Okay. In pharmacology too, there is a chapter on the GI type medications. Okay. Especially there's a chapter on ulcers. Okay. I want you to read that. Come for the next class. So I'll just be reviewing those things and getting into now therapeutic aspect for the peptic ulceration. Is that clear?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
We will close the class now, but next class, I want you to come prepared with that. So we'll just look at bleeding peptic ulcers, and then we will look at the therapeutic options for the this with various method strategies, including acid suppression and the class of drugs available for the therapeutic for the peptic ulceration. Is that clear? Okay.
Yes, sir.
We will see if possible today or next week we'll have our next class. Okay?
Okay, sir.
Okay. Okay. Good. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.